Atul Goel, who is professor of neurosurgery and head of the Department of Neurosurgery at the KM Hospital and SET Medical College at Mumbai in India since 1998. He's honorary consultant of neurosurgeon at Lilavati Hospital and Research Center since the beginning of 2000, and honorary consultant to Governor of Maharashtra State, India in 2009. President of the Skull-Base Society of India in 2004, Vice President of Asia Society of Neurological Surgery in 2006, President of the Asia-Oceanian Skull-Base Society from 2011 to 2014. He's honorary member of several neurosurgical societies of the Japanese, of the Venezuelan, the Egyptian, the Bangladesh, and Italian. He's chairman of editorial board Journal of Neurosurgery Spine, section editor of World Neurosurgery, editor-in-chief, International Journal of Neurology and Neurosurgery, and editor-in-chief of the Journal of Craniovertebral Junction and Spine, had several awards and honors. I just list the last ones, which is the Dandy Medal for Distinguished Neurosurgery Service 2018, and Outstanding Contribution Award of the Chinese Neurosurgical Society in 2019, International Ambassador Award by the Congress of Neurological Surgeons at San Francisco in 2019. And as Chuck just mentioned, he had a damn lot of publications, so I will skip these. And yeah, it's your stage, Professor Goel, talking about the versatility of middle fossa approaches. Thank you.
Thank you, Hasham. Let me get my screen on. So I am going to talk to you on the versatility and variability of middle fossa approaches. You see, middle fossa approach is a very important neurosurgical approach, and you learn it, you grow with it, and as you grow, you modify it, and then you modify it further, and then you seek alternative options. So what I'm going to do is, I'm going to go through the journey of mine through this middle fossa approaches. So this book I wrote with Professor Kobayashi in 1996. Now you see the cover page of this book. Cover page shows that the whole petrous bone has been drilled off, Gasserian ganglion has been elevated, the entire petrous carotid artery has been mobilized, and the entire facial nerve has been mobilized. So you can imagine the way I was doing it at that particular point of time, and you see my journey. I became, I'm head of department of neurosurgery at my hospital, which is a public hospital, which is a completely free hospital for people. And you can imagine the workload. So I have been in high volume center throughout my life. And that has given me quite a bit of an advantage, as you will see. So middle fossa is quite a dynamic structure, holes and crevices and bony edges and ledges and things like that. And you have to work your way through, and it is a journey. It has to, as Dr. Borba said, we have to have anatomical concept. And as Dr. James has shown through various surgical pictures and videos, you have to know anatomy in absolute three-dimensional perspective, that is one, and you have to know the anatomy in pathological situation when there are tumors. So this is when you open the middle fossa, you see these are the membranes of the temporalis muscle. You know of the superficial temporalis fascia. There is a deep temporal fascia. So there are two layers defined of superficial and deep temporal fascia, and there is a pad of fat underneath these facial layers. And then there is a gallial layer. So this is subgallial, two layers of fascia. So in the year 1995, I described this additional layer called subgallial fascia and used it with the pericranial. Pericranial cranium is the continuation of superficial temporalis fascia. This thicker layer is the deep temporal fascia. Superficial temporal fascia goes above it and it continues like pericranium. So we had used long time ago pericranium plus temporalis muscle. So there is temporalis muscle, superficial temporal fascia, deep temporal fascia, and subgallial fascia. So this layer was mentioned as a layer first time in the neurosurgical literature in this article. And I have a feeling that when you are making long vascularized pedicle flaps, this subgallial fascia is an important layer that one can use. This is a middle fossa defect, as you can see, and you can use that subgallial fascia pericranium as a vascularized pedicle flap. So in the year 1995, you see here, this is the muscle and this is the bone. So we have used an osteomyoplastic flap. So there is bone and there is muscle, and this has been rotated to cover this middle fossa floor defect. So I called it as osteomyoplastic bone flap, vascularized osteomyoplastic. So there is bone and there is muscle in 1994. And then what we do is we take a split cranium from here and use that to repair the skull. So you see there is repair going on here, and there is a big middle fossa repair with bone. Whether you need bone, whether you don't need bone, that is a different matter. Whether you want to put fat first, fascia first. Of course, now I will not use this bone for reconstruction here. Fascia is a good enough, vascularized fascia is good enough. But I had described this, so I am showing you in 1994. Then I use another layer for reconstruction. You see, this is a temporalis muscle. This is superficial and deep temporal fascia and the vasculature of the temporalis muscle. I split this muscle here, split cranium here, and then move it as a long vascular. So this is a long vascularized pedicle skull flap, and you can mobilize it in this fashion, and you split the bone like this. And this can be used. So there is a frontal bone defect. This is split from here, and it has been placed here. This picture is from my paper in 1995, long vascularized pedicle cranial flap. Then you see this beautiful flap. This is a, you see, I cut the superficial and deep temporal fascia here and elevate it. And then there is a long fascia muscle flap. Then I cut this whole thing, and there is a vascularized muscle fascia flap. So extended vascularized temporalis muscle fascia flap. I published this in 1994. And I use this flap very often, particularly when we do glomus tumors, when we use chordomas for skull base, quite extensive bone work. This flap is very useful flap and very versatile, and you can move it from anterior to posterior, and you can use to line the entire cranial base in a very effective manner. And these vascularized flaps are very beautiful flaps. Now you see there is a huge skull defect here in the middle fossa, and there is CSF coming from here. This is picture of mine from 1994, so 26, 27 years ago. And you see there is a big, huge skull base defect. So what I do is I use muscle fascia flap and also osteomyoplastic flap. So first I rotate this muscle fascia flap, and then osteomyoplastic flap, and then cover this. So this is a method to reconstruct a very elaborate skull base defect, as was mentioned earlier. And this, I call it, you see, this is the bone here, multi-layered reconstruction of middle fossa floor using vascularized flaps. So it is, this word vascularized flaps is very important. Another flap I used, may be used or may be usable or not, I'm not sure. But in 1993, I described this technique of using the outer layer of dura as a pedicle flap. So there are multiple flaps of mine which you will like to go through. And these are all vascularized pedicle. These are middle fossa, and I have described several flaps for anterior cranial fossa reconstruction, which you might like to see. Like this flap, you can see this is a vascularized bone flap for anterior cranial fossa reconstruction, which I described in 1994. So there are various reconstruction methods which you might like to use. So middle fossa is a very versatile surgical avenue, and you can go anterior and remove this. Also from my book in 1996, remove the anterior clinoid process, expose the optic nerve, and expose the frontal brain and the temporal brain, and then go basal. So you can reduce your exposure. I must say that I very rarely use extensive skull base exposures at this point of time. This is, you see, this is the temporalis muscle, which can be very thick on occasion. So when you retract over the zygomatic arch, you lose a lot of space. So that is why you do zygomatic osteotomy, to have this extra space in the skull base floor so that you can go in this direction. So we had described the splitting of the temporalis muscle in 1997. You split the temporalis muscle and then use this basal exposure. You can drill, so you can avoid the drilling of the zygomatic arch. And I must say, for last several years, I have not done any zygomatic osteotomy for several years. This is another way to split the temporalis muscle. For I use this splitting of temporalis muscle and make a small craniotomy here just over the foramen ovale, and drill the middle fossa floor from all kinds of trigeminal neurinomas, which I will show you. So this splitting has a great benefit, and it also helps in retaining the function and doing a very quick fire job. In the year 1996, I described this basal extension of craniotomy for subtemporal middle fossa approach. So you please see this, what extension I do. So this in 1996, I made this incision. You see, this is incision. Instead of incision coming like this and going over in the hairline, this is an alternative incision which is centered on the external ear canal. And then the temporalis muscle is rotated anteriorly. You see this anterior rotation of temporalis muscle. You can do this temporal, subtemporal craniotomy and go in this direction. And you don't have to then, even you can avoid doing the zygomatic osteotomy. Then what we described is, we did at 1996, now of course I don't do this, root of the zygoma, removal of the root of zygoma, removal of the roof of external ear canal, and mastoidectomy. So we, in the subtemporal craniotomy, for the first time in the literature, we included mastoidectomy in 1996, and this mastoidectomy added quite a huge exposure from the middle fossa to the posterior fossa, and then did sigmoid sinus mobilization and things like that. But this was the thing that I described in 1996, and I was using this exposure on quite a regular basis. So after doing this root of zygoma, roof of condyle, roof of external ear canal, and having, this is an extradural exposure to the gasserian ganglion, foramen ovale, foramen rotundum, and this is the petrous bone. This is the kind of exposure was possible with this basal craniotomy that we described. So with this basal craniotomy in 1995, I did 18 cases of trigeminal neurinoma using this basal exposure of trigeminal neurinomas. I also used the same exposure, removal of root of zygoma, roof of condyle, roof of external canal, partial mastectomy, and I published this article in 1999 for 24 cases of extended lateral basal subtemporal approach for petroclival meningioma. And I found very beautiful this exposure at that point of time. Another thing, you see, you do intradural exposure, you retract the temporal brain. You, we describe this technique of tentorial dural flap. Of course, Drake was doing all the time tentorial cutting for basilar artery aneurysm, but dural flap was described first by us in this article in 1995. Cutting, you see how I identified the fourth nerve, separated the fourth nerve, and then cut the tentorium in this direction, and then elevated it as a flap, and then did posterior fossa exposure after mastoidectomy if I have to go more lateral. So this kind of exposure was done on a regular basis earlier in my surgical experience. The other thing that I described is, you see, this is the greater superficial petrosal nerve. This is the geniculate ganglion. This is the facial nerve. This is the facial nerve segments of the facial nerve. This is the mastoid segment. This is the tympanic segment. This is the labyrinthine segment of the facial nerve. You cut the GS from the, when you are approaching from middle fossa. I'm not saying when you are approaching a big exposure, but when you are exposing from the middle fossa to expand the Cavernous triangle, if you mobilize the facial nerve, just these two segments, you can have a very big exposure of the middle fossa floor, and then you can go and hit the middle fossa, complete removal of this bone, save the carotid artery, and then, of course, GSPN should be cut when it is absolutely necessary, or it should not be cut. So we describe this sectioning and partial mobilization of the facial nerve in this article of mine, extended lateral subtemporal approach for petroclival meningiomas, when we did this kind of facial nerve mobilization. I must say that this is my history. I don't do these things now, and I will show you what I do now. So this was my book, and these were the exposures, and I call this quite a historical exposure of mine. So cavernous sinus surgery, I have been involved for last at least 30 or 35 years now, and various articles of mine right from 1998, 1996 on meningeal architecture and surgery on cavernous sinus. For various articles are there talking about the dural anatomy, talking about the arterial displacement and how your strategy of cavernous sinus surgery should be done, how the meningeal relationship of the tumors varies from one tumor to the other, and how you can get the histology of the tumor just by looking the relationship of the vessels is a very important. I consider these articles of mine as very beautiful articles on cavernous sinus surgery. More importantly, my hospital gives me an opportunity to do several cases. You see, I do sometimes 10 or 11 or 12 or 13 cases a day. You will be surprised to know that number, but that is a fact. In 1993, you can imagine this middle fossa approach I did with very extensive petrosectomy, basilar artery encasement, various arterial encasement, and you can imagine, and this patient, 1993, so 27, 28 years ago, and this patient is still alive with meningioma, without a meningioma. Of course, he never allowed me to do a repeat scan, but this patient continues to be blind, and he was blind when I saw him. This is another tumor I did going in the orbit and going everywhere in cavernous sinus in 1995. This is another case in 1997. You can imagine the extent of radicality of surgery, which we used to do, and we still do. Radicality has not reduced, but my exposures have certainly reduced over the period of time. In 1995, I must show you this tumor, which was one of the most dramatic tumors I have done in my lifetime. This tumor was operated by somebody else, and he did retrosigmoid operation. He touched the tumor and he lost 4 liters of blood. And then this patient was referred to me, and I was quite a young man at that time. Even now, I'm quite a young and aggressive personality. So he referred to me and he said, okay, Dr. Goel, you do it. And I did a petrosectomy here. And by the time I did petrosectomy, I lost another 4 liters of blood. And I sent this patient back saying this patient cannot be operated. But this gentleman, who was a young man at that time, he came back to me. And you see, uh, this was the tumor. We had already done the petrosectomy. Then I removed this tumor completely. And you see the postoperative vascularity. We did intermittent occlusion of the carotid artery. You see, the whole thing is coming from the carotid and external carotid, ligated the external first, and then intermittent. We did balloon occlusion tests. He did not tolerate. So we did intermittent occlusion of the carotid artery, and then I removed this tumor beautifully. So this is my surgical success. And this patient was an ossified glomus tumor. So cavernous sinus, middle fossa floor, and dural anatomy has to be learned and has to be understood and has to be absolutely perfected if you want to know how to do these tumors. You have to know the anatomy of the petrous carotid artery, anatomy of the various nerves in this region, more importantly, the dural anatomy, which I will now like to show you. So this was the paper on extradural approach to lesions involving cavernous sinus. When I say lesions, I'm talking of tumors. So this was amongst the very first papers talking about tumors of This is not the one of the very first. This was the first paper which talked about tumors located inside the cavernous sinus, not trigeminal neurinomas, inside, by an extradural approach. Of course, Vinco Dolenz described for vascular lesions and aneurysms and things like that. But for tumors, this in 1997, this was the first article. So this, when you elevate the dura, as was mentioned earlier by Harsham, if you do lumbar puncture, you can elevate the dura very effectively and easily. Then you cut the middle meningeal artery at the foramen spinosum, and then you can retract the extradural beautifully, and then you can go further. So this tumor is one of the most vascular tumors in neurosurgery that you will ever encounter. These are cavernous hemangioma of cavernous sinus. And I did these tumors are completely intracavernous sinus. They go towards the sella through intercavernous venous connection, goes towards the orbit, goes towards the Meckel cave. Lateral dural wall is always intact. They are primary intracavernous sinus tumors, most vascular and most benign. They encase the carotid artery. I published this, and I don't think there is any paper in the neurosurgical journals where pre-op and post-op images have been shown. I showed this in 1991 in one of my articles. These tumors are primarily intracavernous sinus, and we described an extradural approach for these tumors. See, this is a huge, no matter how big this tumor becomes, the dura remains always intact. These tumors encase carotid artery. The third, fourth, and fifth nerves remain within the dural confines. They are never transgressed by the tumor. Sixth nerve is intracavernous and pushed medially towards the floor of the middle fossa. Carotid arteries encased. To operate these tumors, if you make a mistake of pituitary tumor and come through the nose, taking that endoscope tool, and you will land into very serious problem with bleeding, which you may not be even able to control. So these tumors are extradural tumors. Cavernous sinus is an extradural entity. Extradural approach I described with 13 cases in the year 2000. Now my experience with cavernous hemangiomas is 46 cases, personal experience. I think this is the largest experience in the field. So this is a cavernous hemangioma. These are just, I will show you quickly the video. And here these tumors are located inside the cavernous sinus. And I'm splitting the Gasserian ganglion to expose this tumor. You can see the huge. Now, if you get, if you say my technique is I coagulate and I coagulate, then you can just not remove these tumors. These are hugely vascular tumors which you have to aggressively work with. You have to remove the tumor, and you just cannot say, I want to have a clean field and avascular field. If you have that kind of concept, you will never be able to remove majority of tumors located in complex regions like petroclival areas and cavernous sinus. You have to work within the dural, within the bleeding territory. You have to have a red, as Harsham was asking whether you will coagulate or not. No coagulation. You remove the tumor and coagulate pointedly. Many of the tumors, which I will show you subsequently, can be removed without a single coagulation. These tumors are vascular tumors. Once you open the cavernous, remove the tumor, the cavernous sinus will bleed furiously. And then you have to get the lateral trunk of cavernous sinus. And once you control that, you see now I'm getting the artery. And once you get to the artery, you coagulate and the bleeding will quite hurriedly stop. And then you have a panoramic view of the whole cavernous sinus, and then you can remove the tumor, whatever is remaining, in a beautiful fashion. This is the only tumor which will give you a huge anatomical display, and you have to work over the carotid artery. If you work lateral to the carotid artery, you can have sixth nerve in danger. What you have to do is try to go outside the tumor, identify the sixth nerve early in the operation, save it, and keep it protected. And then you remove the tumor. And then these tumors can be removed. And this is almost an unedited tape. You can see that within about 5 minutes, maybe this tumor has been removed. And this has been, this benign tumor, his can be removed completely, provided is that you learn the art of working in bleeding territory. If you don't have that art, you just cannot, you may not be able to remove these tumors, or you may have very serious difficulties in removing these tumors. So this is pre-op and this post-op now, as I mentioned to you, and this my article is coming very soon on my current experience with cavernous hemangiomas. This is another case, this cavernous hemangioma. Extradural approach is the only approach for these tumors. You just cannot, I don't want to show the whole. Now, you see, this is also my little bit oldish video. And extradural, you see, I am opening extradurally. Then what I'm doing is, you see this, the trigeminal nerve has its own dural layers. This is V1, V2. First, I tried to do between V2 and V1. Then I'm going between V2. You see blood is moving all over the place. Now, if you start coagulating, you will have an unending operation, which you will never be able to finish. This is a bleeding operation. Once you get to the tumor and you start removing, you will have a panoramic vision. What I'm trying to do first is to identify the sixth nerve and save the sixth nerve and protect it. You see, there is the sixth nerve. What I'm doing, and you can identify the sixth nerve at the petrous apex along the floor of the middle fossa. And then you remove the tumor, and then you remove the tumor away from the sixth nerve. So this is the carotid artery inside the cavernous sinus. If you make a mistake of coming through the nose, you will have your finger and all your fingers in your nose, and you will never be able to remove this absolutely dangerous tumor. And you see this patient who had third nerve deficit before operation has completely recovered in the third and sixth nerve. And you see this is the only way you can deal with this problem. Anatomy is the key, as was mentioned. You have to know the anatomy in all dimensions. Now I want to talk about trigeminal neurinoma, and James will be little bit interested to learn about these tumors from this article of mine, which was published in 2003 with 73 cases. At that time, this was the largest series in the world. Now my experience is more than 300 cases, which is also the largest series in the world. We introduced the concept of interdural exposure. And this article was the first where we mentioned that you remove the tumor, you can save the sensations of the fifth nerve, and you can improve the sensations of the fifth nerve. So these are interdural tumor, and we also subsequently mentioned that even this part of the tumor can be interdural, or majority of times it is intradural, as we know. So in 1995, I removed these trigeminal neurinomas on the basis of clinical impression that this is trigeminal neurinoma. The hands of the surgeon are like this. I remove the middle fossa floor, open the foramen ovale, and remove the tumor without doing any craniotomy. So this was in 1995, infratemporal fossa interdural approach. This word interdural approach was used first time for trigeminal neurinomas. And this was in my article, this picture, you see pre-op and post-op by just doing very small exposure. This was also in my same article where I removed this tumor on the impression that this is trigeminal neurinoma just by doing this craniotomy, opening the foramen ovale, working within the dura, interdural approach, and even removing this posterior fossa component in 1994 without doing any craniotomy. So this is what the anatomical understanding will help. So this is another tumor with the same kind of exposure. But most of my cases are huge and large, and I like to use basal extension as I mentioned, and this is my exposure. This was my exposure, now not this exposure. First extradural, then open the dura, and then learn the art of demolishing the tumor. You can do a quick job. You see, this is the exposure, splitting of the temporalis muscle. Just do this small craniotomy. There is no need to do any petrosectomy. James mentioned about petrosectomy, Kono mentioned about petrosectomy. No petrosectomy, because this tumor does the petrosectomy for you. You come, open the dura, work within the dura, learn the art of demolishing the tumor, break the tumor, break the tumor, break the tumor, and don't coagulate, and you will be able to save the fibers of the fifth nerve, save the fibers of, and save the function of the fifth nerve, and do a quick job. Without a single coagulation, you can remove this tumor. Then, of course, there may be 1 or 2 or 3 coagulation here and there. But if you know the art of operating within a bloody territory, if you know the art of demolishing the tumors, these tumors are one of the most beautiful chapters of neurosurgery. And as I mentioned, now I have experience of nearly 300 or more than 300 cases of trigeminal neurinoma in beautiful fashion. And these are the cases which you must have seen before. These tumors are come from here, make a small craniotomy, lateral exposure, open the dura, and then anterior posterior exposure, learn the art of breaking the tumor, breaking the tumor. There may be a huge hole in the petrous apex already. If not, come intradural, open the tentorium, make a tentorial dural flap, preserve the superior petrosal sinus if possible. If not possible, cut the superior petrosal sinus, work within the dura, and you will have the most fascinating result that you could have ever imagined. If there is a small nubbin, does not mean it is going in the cavernous sinus. It still means that there is dura. Work within this tumor, and I will be very disappointed if I take more than 1 hour to do this operation. 1 hour is actually too much for me to do this operation. This is a quick job, precise job, small craniotomy. Of course, as I mentioned, I was doing much larger exposure earlier in my field. This picture I brought just to show you how much petrosectomy has been done by the tumor. I have not done how much anterior clinoid process has been removed by this tumor. And if you say I will do petrosectomy, and if you do, I will combine petrosectomy, I think you will have to have much more experience in dealing with these kind of problems. Even extracranial tumors which have a dural layer, and you can go transcranial to do this extracranial tumor resection, which is, and work within the dural confines, and I call it a reverse transcranial skull base operation. Even when the tumor recurs in an apoplectic fashion, it remains within the confines of the dura. Understanding the fact that these tumors are within the dura, you can do a beautiful job, and you can do a quick job, and you can do a small exposure. This is another tumor, which is a third nerve tumor. And if you will, if you do not know what this tumor is and what are the dural limitations of this tumor, you will never be able to save the third nerve or do any justice to the third nerve. You must remember that these tumors arise from the oculomotor system. They remain within the dura. You work within the tumor, demolish the tumor, Don't remove the dura, or don't consider it as a capsule of the tumor, and you can save the third nerve. You see the third nerve is saved, which has never been described in the literature. Learn the art of demolishing the tumor. Learn the art of respecting the dura, and learn the art of avoiding coagulation, and you can save the third nerve function. You see the dural cover around the third nerve, and you don't have to remove this dural cover. You have to save the dural cover. It is only the sixth nerve which will encase the third is carotid artery, and then of course you have to do whatever you have to do. Similarly, this is the middle fossa tumor. This is a 7-nerve neurinoma. 7-nerve neurinoma arise from the geniculate ganglion. If you have the concept that these tumors are within the dural confines, you don't need to do any major petrosectomy or any kind of heavy exposure and 5 hours or 10 hours exposure. You come subdural, extradural, open the dural membrane, preserve the course of the 7th nerve along the petrous apex. I am not saying I have been able to save the 7th nerve or improve the 7th nerve, but that is the only chance if you do not remove this dura, which may be misunderstood as capsule of these tumors. Similarly, you see, I'm just giving you introduction to these papers. Similarly, I identified interdural surgical strategy for lower cranial nerve schwannomas. Lower cranial nerve schwannomas are also interdural, respect the dura, and I have mentioned in my article, all my cases, you have the possibility of improving the lower cranial nerve function. Now I go to a tumor, chordoma. Chordoma is a tumor which all the endoscope happy people will like to go through the nose, but these tumors have very specific bone destructive capacity, and they displace the cranial nerves and displace the carotid artery and displace the dura. So these tumors destroy the bone, but they don't have the power to displace the soft tissue. Carotid artery is displaced anteriorly, cavernous sinus is displaced superiorly, the dura is, these are extradural tumors. So lateral perspective is a beautiful perspective for many of these tumors. Chondromas and chondrosarcomas. You see, this was an article I published in 1995 about carotid artery. The whole carotid artery is displaced anteriorly. And if you have a lateral shot, there is no carotid artery, and you can work visualizing the cranial nerves in your field. I'm not saying I will do all my chordomas by the nose and not by, there are many chordomas in the midlines with midline which endoscopic can be useful, but many of these tumors like this kind, I say middle fossa, subgastrian ganglion approach for clival chordoma, which I described in 95, is a beautiful approach for these tumors. Carotid artery is displaced anteriorly, dura is displaced posteriorly. Work within these tumors, remove the tumor, and you will find that you can do a quick job. And the sixth nerve is in question. And this is a tumor chordoma, which I will just quickly show you the video. You see, when you are operating in a chordoma, if you have all the cranial nerves in front of your eyes, carotid artery in front of your nose, all the cranial nerves visualized from all perspectives, you can certainly do a much more beautiful operation than using the nasal avenue. In some rarest situations, not rarest, but in rare situations, you must use endoscope for midline tumors and all those things. But when the tumor is going lateral, this is a transcranial is a beautiful approach. I described recently supracerebellar approach. I don't want to say that this is a good approach, but you see supracerebellar approach for clival chordomas. You see this tumor, if you come from lateral, of course, lateral is the best. I'm not saying lateral is not the best, but to save the sixth nerve, you see sixth nerve, if you identify the sixth nerve early in the operation and then save the sixth nerve, you see this supracerebellar retrosigmoid approach, I remove this tumor completely right in the nose. So I can save the sixth nerve, which no nasal route can possibly identify. If you come from the nose, the sixth nerve will be last to be seen. If you come from lateral, the sixth, I'm not recommended. Please don't misunderstand me. But a tumor chordoma, which is right in the posterior fossa, a supracerebellar approach can be used. Most importantly, they have very specific relationship with the carotid artery, which I have mentioned in my article on the subject. and you wish to, I suggest you please read that article, and this can be a beautiful approach. This is another tumor which I use supracerebellar approach. You see how um, with the concept that the dura will be intact, with the concept that the carotid will be anterior, this direction of surgery, you see the whole tumor you can remove, and you can possibly, this is the best shot at the 6th cranial nerves. So for middle fossa, this nasopharyngeal tumors, of course, you can use endoscope, and nasopharyngeal angiofibromas are the most beautiful nasal tumors to be operated. Midfacial deglobing is a beautiful approach. I described in 1994 transcranial middle fossa approach for these tumors, but I do not recommend now. You see, now this is history gone. If you use nasopharyngeal angiofibroma with this approach, I don't recommend it, but this is what I described. So there are several cavernous sinus tumors like epidermoids, teratoma, dermoids, aspergillomas, tuberculomas. For meningiomas, as I mentioned, I used to do very extensive exposures for tumors like this, but now my exposures have become quite, and this is my beautiful editorial, which you will like to read in Journal of Neurosurgery, of my concepts on cavernous sinus meningiomas, how to remove these tumors, what to do about these tumors. This is arising from this vascularity, arising from the posterior wall of cavernous sinus, how to approach this tumor, how to approach this posterior. These are more benign types of cavernous meningiomas. I described in 2004 supracerebellar approach for petroclival meningioma. Many surgeons in the world are doing this approach now, but this was the first article which discussed supracerebellar approach for petroclival meningiomas instead of doing total petrosectomy and partial petrosectomy, which I was doing earlier. And there are many tumors like this, which I have done by supracerebellar, huge number of cases, which I don't want to discuss too many now here. Even the middle fossa component can be removed if you are doing supracerebellar operation. And this is one tumor which you can go, and this is the 5th nerve, and you can easily, not easily, nothing is easy in neurosurgery, you can expose the cavernous part of the tumor. So these kind of tumors which are predominantly focalized in posterior cranial fossa, it will be quite a unnecessary petrosectomy to do. You come from the supracerebellar retrosigmoid and you see huge exposure you can get. And if you say, I will do transpetrous and I will do, now I will be very, very unhappy if somebody says, I will do petrosectomy for removal of this tumor, which goes right up to mid clivus and lower clivus. And you see, you can get a huge exposure. Of course, I don't have the time to talk too much about these kind of exposures, but retrosigmoid, this exposure, if you say I will do petrosectomy and do this thing, I will say absolutely not necessary. And you can have a beautiful retrosigmoid supracerebellar approach for these tumors, which is a beautiful, only one thing is there. If you want to do these operations, you have to learn how to operate quick fire. If you want to just go on doing this operation for 10 hours or 15 hours, then you cannot do with these kind of operations in that. Then you need very extensive petrosectomies and all kinds of exposure. You have to learn the art of operating, demolishing the tumor in a subarachnoid plane. You have to learn the art of demolishing the tumor without coagulation, minimum coagulation, and that art has to be learned and acquired and experienced. So thank you very much, my dear friends. Harsham, I hope you enjoyed this presentation.
Yes, thank you very much, Atul, for this, for giving us your vast experience over decades and some historical aspects also. And interestingly, the osteomyoplastic flap, if you go further into history, the early pioneers, and a German called Fedor Krause, who published a book in 1908. This was the first technique, because they did not remove the bone flap as we do it normally today. They left the bone flap at the muscle, also in the, for example, in the posterior cranial fossa, and did not remove it. So it was attached. So it is an old technique, but of course it was not used to cover the skull base. I think very important is also that in skull base neurosurgery in general, you have to think how to, before removing any lesion, you have to think how you have to cover the skull base. I think this is a very important point because there's nothing, I think, more frustrating if you have done a beautiful surgery and then the patient has got a CSF leak and you have to come back and look for it and solve it. And this is a very frustrating experience. So thank you very much for your great experience. Open the discussion if you've got any questions. Just one point to clarify, I do not like to coagulate. That's very important. I'm against coagulation, so only if it is necessary, because coagulation denaturates and destroys, and so I'm not fond of coagulation.
James, what do you have to say? James.
Professor Goel, that was a tour de force, an impressive body of work that you've demonstrated in your lifetime career, and certainly something to aspire to. I agree with a lot of the principles that you demonstrated, and I still think, I have a preference for, like you said, the tumor creates the corridor for you. So you showed some very nice giant neurinomas where you can work directly through the pathway of the tumor. I still think in some cases doing some petrous removal gives you the extra space that you might need, and maybe for the younger people who are starting out, I think sometimes you have to be prepared to remove some bone to create some working space.
No question about that, James. As you heard, that I have been doing all these things, this bone work, this extensive petrosectomies, extensive mobilization of the carotid artery, facial nerve. I described facial nerve mobilization. So I was doing a lot of these things earlier in my career. But as you have seen, that over the years, my exposures have become a little bit less. Of course, I still do petrosectomies quite a bit, but many a times I avoid doing exposures which are avoidable. Like for trigeminal neurinomas, I can avoid. Means no question. Now I have got experience of 300 cases. So that experience also matters. You see that experience of handling the tumors, how you can debulk the tumor. These tumors are not vascular tumors. Trigeminal neurinomas are necrotic, soft tumors. I have got ossified trigeminal neurinomas, 4 cases in my series. But in general, they are soft tumors which you can debulk in a very effective manner using, whatever instrument you use. And these are not vascular tumors like even meningiomas are vascular. They can be very heavily vascular, but trigeminal neurinomas are completely not vascular tumors. So if you go on coagulating and all, is not necessary. Very rarely. You see, of course, you need posterior fossa exposure at times. So I mentioned that when I need to go into the posterior cranial fossa, I will then come intradural, cut the tentorium, make a dural flap over the petrosal, superior petrosal sinus, and then work over the superior petrosal sinus and under the superior petrosal sinus. If necessary, cut the superior petrosal sinus and avoid bone work in that area. I'm not saying avoid to avoid. If you need, of course you have to do. If you are not getting into the corners, of course you have to work and get your exposure in a more elaborate fashion. Or you cannot say I have left half the tumor because my exposure was not there. I agree with you. Not that I am not saying that you don't do exposure, but what I have a feeling that we have to learn the anatomy of the tumor in respect to its anatomy, in respect to its dural relationship, in respect to its arachnoid relationship, and we have to understand how the arteries will be displaced, how the cavernous sinus, venous sinuses will be displaced, and how you have to work within the membranes to get to the tumor, and how you have to avoid removing the dura around the tumor, and then you have to effectively. So that is what the purpose of my presentation was.
Okay, we have a question here, Dr. O'Toole, from Joanna of Liechtenstein. She says, absolutely excellent webinar. Huge thank you for all the presenters. Do you use CUSA 2 for cavernous tumors or petroclival tumors?
Yes, yes, of course, CUSA is a wonderful tool, but you know, CUSA also can be avoided in many of these cases if you have a very good control on your suction. You can break the tumor, retract the fibers, retract the membranes with the suction. Of course, when the tumor is of specific quality, you have to use the whatever tools are necessary. But as was mentioned earlier, anatomical understanding of the region, a three-dimensional perspective to the whole area, absolutely precise understanding of relationship of the blood vessel, and experience of demolition. This demolition drive has to be perfected with experience with more and more and more and more tumors throughout your life. Enjoy being in the theater, enjoying watching the cases, enjoying doing the cases. I think that is what we have to do and learn and perfect in our careers.
Goel?
Yeah.
Goel? Could you tell us the patient position in doing a supracerebellar approach for the petroclival meningioma?
That is another
Semi-sitting.
beautiful. That is a question that you have asked me, which is a very important question. Supracerebellar approach cannot be done in lateral position. It can be done, but it can be very difficult to do. So if you are not familiar with sitting surgical operation, sitting position or semi-sitting surgical with head tilt here and head tilt there, you will be able to go in the corners in supracerebellar route. If you are not familiar with sitting surgical position, then of course this approach is not possible. I thank you for asking me this question, because this is very critical, because I understand that in many countries sitting position is not done. Like in US, probably it is not done, but many people even in US are doing. I know Bill Coldwell is doing, I know Yasser Gill was doing, I know Sami was doing, I know Leonard Malice was doing, I know several very senior people in the world in our life of neurosurgery were using and exploiting this route. I know Yasser Gill was using on a very regular basis. Now Ugur today is organizing a conference on sitting surgical approach. He's doing a very big symposium in Turkey, and I wish we can all go and join that symposium. This is a very, very important question that, my dear Kono, you have asked me.
I got it. And do you do cavernous hemangioma surgery today? Because cavernous hemangioma is very effective. Gamma knife is very effective.
Now this is another question. You see, cavernous hemangiomas, there were several literatures mentioning that gamma knife is not effective. That there were many papers. But now you see the other thing is, surgery is a beautiful way of decreasing the headache and improving the cranial nerve function. More recently, as you rightly mentioned, many articles are saying that cavernous hemangiomas can be treated with gamma knife. Even from India, there are some articles where they mention that gamma knife is an effective tool. The question is, even glomus jugulare tumors, many people are saying that we should not operate, we should use gamma knife and all those things. But I feel if you ask me specifically for cavernous hemangiomas, and if the patient has already a cranial nerve deficit, if he has sixth nerve deficit, if he has third nerve deficit, and the person has severe headache, I will offer him surgery, because that is the only way you can quickly, you see, you give gamma knife and you say, come back after 2 years or 1 year, it will reduce or shrink in size. You don't know what will happen tomorrow, what will happen after 1 week or 2 months or 3 months. You say, now I've given gamma knife, you keep on suffering with the headaches. And for these kind of tumors who are having cranial nerve deficit, surgery is the most beautiful and the most, you can cure the person without gamma knife. You see, gamma knife is good, but gamma knife is not good for cranial nerve deficits. Gamma knife is not good for in the long term. You don't know what will be the outcome, of what damage to the brain and vital structures gamma knife will do. There are hundreds of complications that can happen. So surgery, when is possible, should be done. And when you think surgery is risky, it should not be done. When the patient comes with only headache, gamma knife may be an option. When the person comes with cranial nerve deficit and headache, surgery is the only option in my view.
I understand your policy. Thank you.
Thank you. Thank you, Dr. Kong.
Professor Atul Gol,
Yes, Victor.
congratulations for this extraordinary lecture. We always learn from you. Best wishes from Mexico, dear friend.
Thank you, Victor. So nice of you. And I know you are such a fantastic, your anatomical dissection, your anatomical work of spinal cord, of brain stem, of posterior circulation, of anterior circulation, of various parts of the brain are one of the most phenomenal chapters of the world of neurosurgery. I will say you are one of the foremost demonstrators of anatomy in the contemporary neurosurgical world. And I wish to see more of your work, Victor, in the coming future.
Thank you.
If you can show your face to the audience, I think that may be a good, if you can remove the mask and show your face. Victor, is it possible?
I don't have the material here in the office, but
No, just remove your mask and show your face.
Okay.
Yeah, okay.
There you go.
That's better. John, what do you think?
Very good. Blow us a kiss, Victor.
I have some friends near from me. Okay.
Okay, Victor. Thank you.
Thank you, Dr. Atul Gol.
Thank you.